perspectiva positiva de VIH, uno de los estudios más grandes del mundo sobre los resultados informados por personas que viven con VIH. Del 2 al 18, el Dr. John fue vicepresidente senior y director médico de la Asociación Internacional de Proveedores de Atención del SIDA, donde supervisó programas de desarrollo de capacidad y coordinó políticas basadas en evidencia en las Naciones Unidas y la Organización Mundial de la Salud. Con 30 años de experiencia en la medicina del VIH, el Dr. John es un médico investigador clínico con sede en Denver, Colorado. Fue coinvestigador principal en el estudio de pacientes ambulatorios de VIH de los CDC del 98 al 2018 y trabajó en Asia Central durante 2 años como jefe de asuntos médicos para Health Connection Internacional, una organización no gubernamental holandesa. Haciendo escritos por más de 100 publicaciones científicas revisadas por pares, el Dr. John ha compartido su experiencia en VIH a través de programas de educación en todo el mundo, donde ha capacitado a profesionales de la salud y grupos comunitarios en más de 50 países, con un enfoque especial en Europa del Este, Asia Central y México. El Dr. John recibió un MD en el 92 y un PhD en Bioquímica y Biología Molecular en el 90 de la Universidad de Colorado. Completó su formación de posgrado en Medicina Interna y de Enfermedades Infecciosas en el Centro Médico de Ciencias de la Salud de la Universidad de Colorado Denver. Tenemos el apoyo con la dinámica de ponencia y traducción del Dr. Carlos Cabrera May, integrante del Consejo Consultar como expresidente del GEVIHS y director ejecutivo de Fundación BAY. Bienvenidos.
Muchas gracias a todos y todas. Me da mucho gusto ver a colegas de todo el país aquí reunidos gracias a la mesa directiva del GEVIHS, a la doctora Alexandra, al doctor Barrera, a la doctora Gaby Villanueva, al secretario del GEVIHS, Julio Ketz, por la invitación, y a todos ustedes y a nuestros patrocinadores por hacer posible este 20º Congreso Internacional GEVIHS. Muchas historias han pasado. Es mi privilegio y honor interactuar con el doctor Benjamin Young, que es maestro de muchos y que el día de hoy está aquí con nosotros después de una convalecencia importante por muchos meses, y qué dicha poder tenerlo nuevamente. Welcome, Ben, and it is an honor and a pleasure to interact with you in this keynote dynamic of the day.
Primero, muchas gracias a todos, especialmente a doctora Alexandra y Dr. Carlos para la invitación a tener una conversación con Dr. Carlos, pero con todos. Okay. Y bienvenidos sus preguntas, sus conversaciones y comentarios. Okay. And I'm very much looking forward, Dr. Carlos, to the conversation. Ayer, algunas de las palabras más profundas por yo son sus palabras. Welcome home.
Thank you.
México y la región en la península Yucatán siente como mi casa. Es por la gente y por sus... Entonces, it's good to be home. Okay.
Welcome home once again.
And I will speak some in Spanish, some in English. When my words fail me in Espanol, I will revert to my native language. Okay, and I'm sorry, but I'll try to make sure that I stay consistent in one language so that it's just more appropriate, I think.
And don't worry, I'll be also translating, some phrases in English, some in Spanish. But how about if we get started? We were talking yesterday about how clinical research has evolved in the world and how important it is today to talk about the very famous Denver principles. Could you talk to us a little bit about it? Refresh our minds, because some of us, know about them, but some of us, are younger, and probably we haven't heard of them. But today they're still applicable.
So maybe I can ask the group: how many of you have heard the word Denver? Conoce la ciudad de Denver. Okay.
¿Alguien conoce la ciudad de Denver? ¿Ha estado allá? Que levante la mano. Ah, look, we have somebody there.
Just a few.
Algunos. Hace mucho
Okay.
frío.
So es una ciudad en el estado de Colorado, en los Estados Unidos. It's my city, although I no longer live there. How many of you have heard, I think I know the answer, of Denver principles?
¿Han escuchado hablar de los principios de Denver? Levanten la mano quienes hayan escuchado hablar de estos principios.
Doctora, sí. Solo uno.
Wow.
Okay. So we will accomplish something.
Yes.
Okay. Denver Principles, I'll say this in English. Okay. So Denver Principles was written by 20 people with AIDS. Most of them would die in the 1 or 2 years to follow. And it was written in Denver, Colorado. Denver Principles was the first document, a statement of the rights of people with a disease to receive medical care without discrimination. No discrimination for sex, for gender, for sexual orientation, for age or race or income. It was one of the very first statements of this. It was one of the very first statements for involvement of community in planning for research, for planning for services, for planning for medicines. It was one of the first statements about confidentiality of medical records. It was one of the first statements for informed consent. And it was one of the first statements for the rights of people to live with health. And it happened because of people with HIV. That statement informed almost everything we do in medicine today, and should inform everything we do in research, everything we do in policy, in guidelines. In other words, it means that people must be involved in their care, that people have a right to care in medicine. Derechos humanos.
Qué interesante, ¿no? Hablar de estos principios de Denver en su totalidad. Este es un documento que fue elaborado por 20 personas que a la época, en los años 80, se reunieron y que vivían con VIH-Sida y se reunieron para elaborar esta serie de documentos o un compendio de documentos que en ese momento tenía por objeto guiar la práctica médica para tratar a las personas que vivían con VIH con dignidad y sin discriminación de todo tipo como la conocemos actualmente, por raza, por sexo, por orientación sexual, entre otros. Hay muchas otras que ya se han unido al compendio de derechos humanos que están plasmados en nuestras constituciones en muchos países. Y este compendio fue uno de los primeros elaborados en el mundo y fue realizado en Denver, Colorado, por estas 20 personas. Además, este compendio guió y sigue guiando, por eso hablamos de su aplicabilidad actual, los principios básicos para generar nueva investigación clínica, nueva investigación biomédica para nuevos medicamentos, nuevas alternativas para prevención, nuevas vacunas, y así como guiar la praxis de los médicos tratantes y sus decisiones clínicas en la atención multidisciplinaria del VIH-Sida. Entonces, este documento sirvió como base para todo ello y hasta el día de hoy sigue vigente.
So thank you for translating my words. So Denver Principles sometimes is very simplified to nothing about us, patients, comunidad, nothing about us without us. So this is a guiding principle really for really all of civil society and medicine. It was that principle that changed the way that Tony Fauci thinks about research. It changed the United Nations and the World Health Organization. And so this is a very important principle that I want to start our conversation with. And I want you all to be proud of the legacy of our patient communities in changing the way that biomedical research and medical care happens. It's because of people with HIV, HIV researchers, HIV doctors, that now has led the world on ideas about human rights in medicine, about health and human rights, about health equity. And all of that is centered around people living with HIV and people who care for them.
And how would you say that you did in those early years, applying those principles in your practice? How did you start in those early days in your clinic in Denver, clinical trials, etc.? How was it for you?
So, yeah, very good question. So, I am a student of, or the son of, the Denver Principles. My patients knew the men who wrote the Denver Principles. So they taught me those principles, much as the friends of these men forced this on Tony Fauci, forced this on very legendary activists to change the way that medicines were approved. So what this meant to my clinic, though, was that I very quickly learned about the importance of having non-stigmatizing, non-judgmental conversations that informed people about their health, informed people about medical care, informed them about treatments, and informed them about research opportunities that affect new medicines and affected them directly. So it was, as we now say, person first, patient first. Right? We help patients, but the patient is the center of what we do. Right?
And through the years, after applying those principles, can you tell us a little bit, we're talking, the last closing session will be about a chronology of events for GEVIHS, during these 20 years. How was it for you, when you started doing your clinical trials? How did you gain that success to be the recognized expert in an international scene these days?
It's my part of that 20 years. Actually, my part of the last 30 years is the answer to your question.
So GEVIHS had to do with it somehow.
Well, GEVIHS was part of that story,
Yeah.
right? So my background, I'll give you another component to this, which is my initial intent in career was not to be a global health expert or even a clinical medicine expert. My interest in HIV was in evolutionary chemistry. So we know that the virus evolves very, very quickly and rapidly in people. And it evolves immunologic escape, it evolves drug resistant to medicines, and it does so in a matter of weeks. So many people who study evolution look at fossils, and we think about millions of years. And as an evolutionary biochemist, I had an opportunity to study this in a matter of days in people where the outcome was either health or death. I never thought that I was going to be a clinical doctor. This is in the early 1990s. But it was only after meeting the first patients that I was told I had to take care of, because I was a doctor in training, that I realized the immense human impact of the work that we were doing. That human impact made the research for new medicines all the more important and urgent. So the medicines weren't just a study of a virus and evolution. these things actually mattered to real people. And in those days, most of my patients were about my age. And in those days, most of those patients died.
How old were you at the time?
So I am now 62. And in 1990,
A recent
I-
graduate from
yeah, I was-
ID,
yeah, yeah,
your
yeah.
ID fellowship
Yeah.
program.
I took a long time to get
Wow.
my fellowship because I have an MD and PhD. But
So you were just starting.
yeah, I was just starting, so I was very impressionable.
Mhm.
So there was both this incredible interest in biology and chemistry and evolution, coupled to, overlaid exactly with this incredible human need to care for people who were often marginalized by the community, marginalized by the church, marginalized by the jobs. They faced the most awful stigma and discrimination, and often died alone because they had been separated from their families, separated from the church. Right? Sometimes their families would prevent their gay friends from attending, their gay partners from attending in the hospital. So I was the person who cared for them in a medical sense, but I was often the person who cared for them as they died and pronounced them dead. To me, the burden of that was immense, the responsibility. But then also there came and the opportunity to do good. And very quickly, the science became secondary. But secondary only to, but it was important because that's the science provided us the ways to develop medicines. And so this is a way of restating Denver Principles. Denver Principles now was like, it was the people I cared for that was really the most important. And finding the tools, the medicines, the diagnostics to help first prolong life and then improve life was really the life calling.
Do you remember the very first clinical trials you participated in?
Yeah. So when I was an infectious disease fellow, at University of Colorado was the epicenter for the AIDS clinical trials group in the 1990s. The executive director, the 3 deputy directors of the ACTG were based at University of Colorado. And I had a recent PhD from a very famous scientist in RNA chemistry, and we thought that we would do great things and solve problems. But I was assigned, as fellows were, to support a clinical trial for your fellowship, during your fellowship. And so I was assigned to a protocol called ACTG 315. 315 was the first ACTG study to use 3-drug therapy. It was stavudine, lamivudine, and ritonavir, full dose. It was horrible, but we were interested in doing viral kinetics. I was a mathematician, biochemist. I was a nerd, probably still am. So what we studied, we measured viral loads in these people every day for, I think, 4 weeks, and then subsequently every week for another 6 months. So we intensely studied the viral decay in the patients, and to our delight, of I think the 20 patients in the study, all of them attained viral suppression, and we began to understand the characteristics of how the virus disappeared from people. And later, of course, we followed these people over years. Some of them developed virologic failure, and we studied the return of virus. So we began to understand the mathematics of how the virus was replicating, how the medicines worked. And actually, interestingly, I worked with another fellow on the project whose name is Kimberly Smith. And Kim Smith is now the Senior Vice President at BEEF for Research and Development. So
How interesting.
So we've known each other now for 28 years.
I was gonna say after 30 years, you find another common pathway, and So with those early clinical trials, we heard Dr. Sierra earlier this morning talking about the HPTN and HBTN studies, the Mosaico study that also Merida took part in, how the networks in the United States and across Europe are guiding also their practice through those Denver principles to include the community advocacy and support groups, and basically, asking the members of those affected communities to serve in advisory boards.
Yes. So when the ACTG learned from Denver principles, and it learned from from the oncology community, oncology researchers who were also charged by the community to inform people with cancer about research. And the same was true with the ACTG, the AIDS Clinical Trials Group, both at the local site and at the national level. So our site, this one study in 1995 involved patients, I believe, in 10 cities. 20 patients in 10 cities, just 1 or 2 patients in each site. But all of that was informed before the study started, in the middle of the study, and at the end of the study, involved communications with the community to help us design the study, help us design how we spoke to patients. It involved everything. Today, it is central, and even the informed consent that we would offer people to sign to join the study was informed by Denver principles. And from that grew other community organizations that were really less research-oriented, but still more oriented towards engagement and helping approve of the way that we took care of people, to make sure that the language we used was understandable by patients, to make sure that the community was informed, whether they were patients or not. So the distance between Denver principles and research and clinical care, there was no distance. They were superimposed, right? And that, to me, is why, even that long ago, why HIV services are so different than other aspects of medicine. And it's why I can drop into an auditorium here in Merida and feel like family. Or I can fly halfway around the world to a Russian-speaking country in Central Asia where everybody is Muslim. They have no real reason to feel like family, but they are family. It's because of this idea that we all actually appreciate the ideas of Denver principles. In that is understanding that the people we often look after are people who have been thought of as discarded from the mainstream community. They were marginalized, discriminated against, sometimes criminalized for the very people who they were, even without HIV. But then HIV added this other layer. So we became, the patients taught us how to take care of them, and they taught me how to be an advocate for them. So I went from being basic scientist to clinical scientist to clinician to human rights activist.
So, does that mean that all of us doctors, treating physicians, who are seeing hundreds of patients, per month, sometimes thousands in Mexico, can do that too?
I would absolutely say yes. Now, this is something that is another part of my journey, right? So when I started, the idea that scientists should not be activists, right? Doctors should not be political or activists. It was the HIV doctors, some of whom were my teachers, some of whom were my mentors and friends, who were really pioneers in the idea of health activists, doctor activists, or scientist activists. Jonathan Mann, who was a doctor in New Mexico in the United States, became the first he founded what is now the WHO response to HIV. A dear friend, a dear departed friend, Job Langa, who was the IAS president, was someone who in 2003 said that, of course, we can bring he said a cold beer or Coca-Cola to every village in Africa, that of course we can bring HIV medicines to every village in Africa. And Joop died, shot down over the skies of Ukraine in 2014. So there is now a long legacy of some of the most proud, most effective health and human rights activists are actually physician researchers.
So that changed your perspective.
Yes, yes, absolutely. Joop Lange, I got to meet Joop when I was a young doctor, and we were at an advisory board. He was there with his family. I was there with my family, my young kids. They were maybe 10 years old. And we went swimming together on a beach in Hawaii. And I thought how I was starstruck that I got to sit on a beach and share a drink with this man who changed the perception that actually people who live in poor countries can have the same medicines as people in rich countries. People with dark skin can get the same medicines as people with white skin. And I took that to heart. Maybe we can fast forward a little bit, and I can say that in 2014 and 15, I got to work with Joop. I was working on international guidelines with Joop, and we were on a mission to write the first evidence-based guidelines that recommended universal treatment for HIV, all CD4 counts, all ages, all countries. And literally, we were working on this when he died. It was very heavy, but the following year, I basically inherited Joop's role on the World Health Organization guideline panel, where in 2015 we said everybody gets treated, all CD4 counts, all ages, all countries.
It's fascinating, and I'm going to pause a little bit just to, talk to the audience in Spanish. Lo que el doctor Ben ahora en esta plática con el experto ha estado platicándonos muy interesantemente. Yo sé que la mayoría de esta audiencia es bilingüe, entiende muy bien el inglés, pero hablar y enfatizar para nuestra audiencia de médicos tratantes y personal multidisciplinario que atiende a personas con VIH, estamos remontándonos en la historia del doctor Ben, cómo él no tenía pensado convertirse en un líder global experto en VIH que lidera ahorita los esfuerzos en VIV en todo el área médica, y cómo a su paso desde su clínica privada en Denver aplicó estos principios fundamentales para la atención integral y la investigación realizados por estos activistas en Denver. Y cómo al principio él no pensaba que los médicos y los científicos pudieran también ser activistas, conociendo a numerosas personalidades del mundo del activismo que sin lugar a duda cambiaron la percepción mundial de que todas las personas, incluso en continentes y países pobres de diferentes razas, colores, etcétera, pudieran recibir los mismos medicamentos que se recibían en el primer mundo. Cambió la perspectiva del doctor y lo motivó más a ser un activista en pro de las personas que viven con VIH. Él nos conmina de esta inspirante historia, su historia, para que todos nosotros, a pesar de estar siempre en la consulta, con muchísima consulta, por cierto, aquí en México, en nuestros distintos sistemas de salud, podamos siempre anteponer los intereses de nuestros pacientes y poder brindarles la mejor atención. No solo la atención médica, siempre decimos, ¿no?, con calidad, pero también con calidez, y también realizar una serie de acciones que los ayuden a involucrarse más en su tratamiento, a ser adherentes, a ser comprensivos de las diferentes situaciones que puedan vivir en su vida cotidiana, situaciones también extraordinarias, para poder ayudarlos, apoyarlos y acompañarlos en todo ese entorno que marca la calidad de vida, que si bien sabemos es biopsicosocial, involucrarnos más en temas de investigación para poder brindar nuevas herramientas a los pacientes mexicanos. Ahorita vamos a hablar un poquito más de eso en esta discusión con el experto. So I was just basically summarizing all of that and how, y cómo, perdón, antes de que se me olvide, los grupos comunitarios, nuevamente los principios de Denver, han sido esenciales en el involucramiento de los protocolos clínicos para que puedan llegar a buen término con esas mismas poblaciones afectadas. Prueba de ello, como hablábamos, el doctor Sierra nos había comentado de varios protocolos que nutrición y también Yucatán ya estamos llevando a cabo en diferentes redes internacionales que son parte de los Centros Nacionales de Salud en Estados Unidos, por sus siglas en inglés, los NIH, que todos conocemos, y que mandatan a los centros de investigación a incluir entre sus estructuras de toma de decisiones a los consejos comunitarios asesores. Es decir, hay que obligatoriamente involucrar a las comunidades para que nos den su parecer y sus opiniones en estos protocolos. Y muchos de los patrocinadores que auspician estos protocolos han tenido que cambiar o enmendar esos protocolos que desde luego tienen que pasar por comités de ética, de investigación, de bioseguridad y por la propia autoridad regulatoria, que en este país es COFEPRIS, en Estados Unidos la FDA, para recoger e incluir todas las recomendaciones que las comunidades afectadas nos brindan. So, just kind of elaborating a little bit more about the community advisory boards and how they've been so instrumental for the clinical trials, in the past, but also now strengthening the efforts in the days to come. And could you tell us a little bit more about how can we talk about replicating successful models?
Well, so successful models have been established in many parts of the world. And we'll principally about research models, right? Okay. So there's a couple of, even before we talk about replicating the models, I think it's important to understand, and this is another lesson from my mentor, Joop, that research has a history of exploiting people in poor countries or dark skin, a colonial view of research where companies or universities in high-income countries go to low-income countries, perform research without the consent or involvement of people, and extract information, and then the people in poor countries get no benefit from the research. HIV changed that. And actually, my two sadly departed friends, Joop Lange and his colleague, Charles Boucher, about 20 years ago set on a campaign to make sure that research programming, which involved communities, involved researchers, was not just happening in Europe and North America, but was happening for their efforts, especially in Africa and in Asia. And so they established research congresses and learning institutions in these other regions. And actually later they would start a similar program in the Americas. So the conferences you may know as HIV in the Americas, the Asia Pacific Conference, and the Interest Conference in Africa were all designed to build the capacity and the interaction of communities with researchers in the global south as a direct attempt to make sure that when we talk about community engagements, we weren't just talking about white people in Europe and North America involved in HIV research, but actually people all over the world, whether they were community and patients or if they were researchers. And so that that notion of inclusion of community, but also inclusion of countries, was really baked into the response to HIV very early in the history of HIV, very early in my career. I feel very fortunate to have known both Joop and Charles, and to have been maybe not there at the birth of these programs, but early in the programs and help support training doctors and nurses and community about how to do research all over the world. My focus was principally in Eastern Europe, a little bit in Africa, and a little bit in Asia. And of course, 20 years of connection with GEVIHS to support the education of doctors in Mexico and other parts of Latin America. So it's integral to what we do. And it's because it's integral in the global sense, we share those experiences with each other. I think for the older people in this, the older doctors in the audience, we can recall a time when we were 20 years younger. I'm looking at you, Dr. Barrera, where we were sharing ideas and sharing the best, the results of research studies, the results of studies, especially about new medicines, because those new medicines, I was here when the medicines arrived in Mexico, and it was important to share not just how the medicines worked, but to share how the clinics use those medicines, how those clinics, in my case, my clinic in Denver, Colorado, informed by Denver principles, how we took care of our patients. I hope that some of that may have rubbed off here in el sureste de Mexico, and in other parts of the world. But this is an idea that we share practices, we communicate with each other. My job now is mostly to communicate the best, the new medicines and science from GEVIHS healthcare, but in part it's also, but what we do is not just medicines, it's actually sharing ideas about how to bring medicines to the clinic, how the clinic can bring these medicines to patients. A lot said.
Pero la noción, ¿no?, de la que hablábamos, de que el cambio es posible para integrar e incluir a las comunidades en todos estos procesos de investigación biomédica, ha sido muy, pero muy importante y trascendental, y ha cambiado también la perspectiva y la forma en la que la investigación se ve en el mundo. Es decir, había un constructo anteriormente de que la investigación de los blancos era experimentando con poblaciones de color. Y el hecho de incluir a las comunidades afectadas por las diferentes enfermedades en los protocolos de investigación ha también incluido y llevado estas oportunidades, estos proyectos a países en desarrollo que también se benefician de la investigación. O sea, antes la investigación se hacía en los países ricos, desde luego se involucraba a los países en vías de desarrollo, pero una vez que concluían los estudios no se le otorgaba al país o al Estado que conducía los protocolos un beneficio posterior. Entonces eran parte de esos tabús en la investigación biomédica que se han ido cambiando a lo largo de las décadas y que por hoy todavía estamos ante una gran deuda con las comunidades, pero sin lugar a dudas se ha mejorado en esta inclusión, esta noción de la inclusión que puede cambiar en gran medida cómo se dan los resultados de estos ensayos clínicos y permanecer en la comunidad a través de estrategias de reclutamiento y retención, a través de estrategias de involucramiento comunitario, que no solamente hablen de un protocolo u otro, sino que estén presentes de manera permanente en las comunidades que conducen estos protocolos en beneficio de estas poblaciones.
If I can follow on this now to what I do now, one of the things I do in my job at GEVIHS Healthcare is to be a leader in what we call our clinical trials diversity task force. Okay? So this is to say that the participants in clinical trials should reflect the composition of the patients. They should reflect community. Right? And this is basically another way of saying nothing about us without us. So our clinical trials diversity is guided by information about the constitution of the community. So in the United States, that means approximately 40% are Black and African American. About 20%, 25% of new infections in the US occur among women. And so the goal is to have at least 25% women in US studies. The goal is to have at least 40% of Black or African American people in US studies, and so on. And this is now, so that process is, again, informed by Denver principles, in essence informed to make sure that we have inclusion and participation of the people we look after in the studies. And we are now working to make this a global effort, but it's difficult because some countries don't have this kind of information, interestingly, especially in Europe. But the idea is to make sure that we are not only doing research in one group of people, to make sure that the research process involves people, involves communities, and is representative of communities. From a recruitment standpoint, Dr. Carlos, you'd be curious to learn that when we looked across many studies, including GSK studies in other disease states, that inclusion of diverse people was most facilitated by two things. It wasn't as complicated as we think. It was facilitated by having study personnel, people, the researchers, look like the people we were trying to recruit. Nothing about us without us. And then secondly, it was helpful to have the communications, the posters, the letters, have images, pictures of people in the communities that we were trying to recruit. So nothing about us without us. And it's not to say that a cisgender Chinese American can't take care of Mexicanos in Colorado, but it means that we have to be very mindful to make sure that people feel welcomed. But a good way to make people feel welcomed is for them to see themselves in the clinic, to see themselves in the literature. That was probably one of the most important things in the analysis of clinical trial participation.
Nada acerca de nosotros sin nosotros. Y eso es algo que resuena en las mentes ciertamente de los investigadores de ciencia básica que crean e idean estas nuevas estrategias de investigación biomédica en el campo del VIH. Y bueno, remontando el doctor Ben con su historia de vida y su historia para llegar a ser el experto que es hoy a nivel mundial, nos comenta que actualmente en VIV él se encarga y coordina esfuerzos también para que las comunidades que se incluyen en los protocolos o ensayos clínicos de VIV Healthcare o GSK incluyan a las poblaciones de diferentes países, es decir, que sean diversos, que reflejen a las poblaciones del mundo, de todo el mundo, del mundo desarrollado y del mundo en vías de desarrollo, para que efectivamente exista esa correlación, ese sentido de pertenencia de las propias poblaciones hacia los estudios clínicos. Hablábamos ayer de, recuerdas, ¿no? Como, por ejemplo, en el estudio Mosaico se nos entregaron pósters para reclutamiento en Latinoamérica de personas que eran latinos de Puerto Rico o de alguna otra comunidad hispana de Estados Unidos, que definitivamente son fisonómicamente diferentes a las poblaciones mexicanas o latinoamericanas, y cómo estos comités comunitarios tuvieron un gran impacto en hacer que se cambiaran estos pósters. De hecho, la doctora Gaby Villanueva, que aquí está, la vicepresidenta del GEVIHS, ha sido parte desde el primer día del Consejo Asesor Comunitario de este protocolo aquí en Yucatán, que pues ha tenido una repercusión internacional muy importante, que desafortunadamente, como todos sabemos, pues no obtuvo los resultados esperados, pero que sin lugar a dudas jugó un papel importante para hacer que los miembros de estos comités comunitarios pudieran ser parte visual del reclutamiento y con esto enganchar a las poblaciones de estos países latinoamericanos a participar en los estudios. How interesting.
Thank you, Dr. Carlos. I'm looking at my clock, and
Yeah,
I want to be.
we're like at the last stage
We're in
of
the
it.
last
So
stage, and
I would like to ask you, just to kind of summarize this intervention. Could you tell us a little bit more about your experience with the HUPS observational study?
Yeah, so this is now old history. Well, HOPS is a is a U.S. Centers for Disease Control study that was started, I believe, in 1994. It is still going. The study was interested in what was happening in clinics, not in the universities, but in smaller clinics all over the United States. So the goal was to have a representation of clinic environments across the U.S. That would capture a representative group of people, gay and straight, white and black and Latino, across the United States, and simply ask what is happening. So we collected data on diagnoses, on laboratory tests, on medicines, hospitalizations, and we did this prospectively for about 10,000 patients in 10 cities. Denver, Colorado was the largest city to recruit to the study. We had about 15 or 20% of the cohort in our city. The goal, though, was to empower clinicians to participate in the research process. Not all university professors, in fact, very few university professors, mostly clinicians. And if they were professors, they were clinical professors. We provided the experiences of our patients. In return, they taught us how to be epidemiologists, how to write research abstracts and case reports. And I'll tell you two examples of HOPS that I think are very important. It was a clinician, my partner in Denver, Kenneth Lichtenstein, who described one of the first cases of lipodystrophy in the world. But then he asked the rest of the investigators, are you seeing this? And several of us raised our hands. And collectively then, the group of clinicians, perhaps a group one from each of these tables would say, well, let's capture what's going on, not just in your clinic, but in all of our clinics. Instead of, let's say, 200 patients, we had 2,000 patients that were in a survey of lipodystrophy. And we did that in a matter of months. And so Ken published this.
Right? Oh, wow.
Yeah,
sorry to interrupt. So, hablando un poco más de los primeros ensayos muy grandes que todavía hasta la fecha siguen corriendo, un estudio clínico observacional que se conoce con el nombre de HOPS, el estudio HOPS, que hasta la fecha, como mencioné, sigue recolectando información. En aquel momento, cuando su clínica en Denver reclutó al mayor número de participantes de ese enorme estudio a nivel mundial, básicamente tuvo por objetivo describir y ver todas estas partes no observacionales en la evolución clínica del VIH. Y en ese momento, uno de sus amigos, un investigador igual muy importante en la época, detectó los primeros casos de lipodistrofia y le preguntó al grupo de pares si alguien más de ese grupo de científicos en ese momento participando en el HOPS había detectado algo similar, y todos levantaron la mano. Entonces, el Dr. Young nos hace igual hincapié en la importancia de cómo nosotros estamos tejiendo redes, no solo en este Congreso GEVIHS, sino a través de otras intervenciones académicas de educación médica continua, simposios virtuales, diplomados, cursos de certificación, etcétera, que haciendo comunidad. Por cierto, muchos saludos a nuestros amigos que nos están viendo en todas partes del país, porque estamos conectados en directo a todo el país y a todo el mundo. De hecho, la doctora Alexa y el doctor Barrera nos comentamos que tenemos participación de Centroamérica, de Latinoamérica, de 10 países. Así que quiero también darles un reconocimiento muy especial a todos ustedes que están viéndonos en toda Latinoamérica, para que vean la gran relevancia internacional de este Congreso GEVIHS. Y relacionándolo con el estudio HOPS, no duden en contactarnos, en contactar a sus pares de México, de otros estados, de otros centros de atención, para poder seguir haciendo esta comunidad científica y médica en beneficio de nuestros pacientes, que permiten continuar avanzando con la mejor atención de calidad y calidez, y reforzar este tema de nada acerca de nosotros sin nosotros.
I love that.
I love it too.
Yes.
You know, how wonderful and fascinating to exchange these moments with you. And would you like to ask the audience if they had any questions?
Oh, that's exactly where I was going. So I want to make sure that we reserve at least a little time for nothing about you without you. So you have any questions or comments?
Y para cerrar este bloque, que pues tuvo por objeto platicar una charla con nuestro experto, que ha sido un máximo exponente del VIH a nivel mundial, un líder de opinión que está cerrando 3 intervenciones solamente en este Congreso GEVIHS. ¿Alguna pregunta pueden hacer en español? Con todo gusto su servidor la traduce para preguntarle al doctor cualquier cosa que se les ocurra, no necesariamente acerca de esta charla, sino de cualquier otra y alguna duda o comentario que tengan. Adelante. ¿Nos pueden ayudar? Gracias.
Hola, buenas tardes. Soy la doctora Carla Navarro, estoy en Cancún y yo quiero preguntar qué es lo que pasa con los migrantes que están en Estados Unidos, cómo le hacen para obtener el tratamiento.
She is Dr. Carla. She's a physician at the Cancun HIV clinic, and she would like to know, do you know about how our migrant workers living in the United States, not necessarily documented migrants, can access HIV treatment?
So a question very important and very close to my heart and areas of concern. In brief, the HIV services in the United States varies by state by state, because the funding is a hybrid of state and national sources. However, the largest provider of HIV services in the US, called Ryan White funded programs, generally does not require citizenship. So in other words, no necesita papeles. Okay? And so that generally means that if you can find your way to the Ryan White program, that you can have access to medicines and medical care.
Es una pregunta muy importante que seguramente muchos de nosotros nos preguntamos, sobre todo porque cada vez más encontramos poblaciones migrantes que llegan a nuestro país, ¿no? Ese sería también otro tema complementar, pero hablando de los migrantes que viven en Estados Unidos y que se atienden en México, que no necesariamente tienen que ser todos mexicanos. Hoy estamos viendo un gran flujo de migrantes venezolanos, haitianos, de Centroamérica, de todas partes del mundo, que llegan con el diagnóstico de VIH y que no necesariamente se quedan en México, que desean migrar a Estados Unidos. La pregunta de la doctora es muy relevante para continuar el tratamiento antirretroviral y la indetectabilidad. Y en Estados Unidos existe una ley, creo que muchos de nosotros conocemos a este niño que se llamaba Ryan White, que murió de hemofilia. Bueno, él vivía con hemofilia, pero murió de SIDA en aquel entonces, y que fue una de las personalidades a nivel mundial que inspiró cambios en la legislatura de Estados Unidos y que habló y testificó ante el Congreso de Estados Unidos a su corta edad antes de fallecer, para decirles a los congresistas norteamericanos que el VIH no era una enfermedad de personas LGBT o más, ¿no? Que le podía dar a cualquier persona, que cualquier persona podía contraer esta infección. Y entonces el Congreso de Estados Unidos aprobó una ley en su honor. La ley se llama la ley Ryan White. Cada año el Congreso de Estados Unidos reaprueba esta ley, y esta ley permite financiar miles de programas en todos los estados de la Unión Americana que no requieren o no solicitan documentos legales a las personas que viven con VIH para acceder a los servicios. La clave está en que podamos investigar qué estados y qué clínicas, porque desde luego hay miles y miles, decenas de miles de clínicas, qué clínicas que atienden con VIH cuentan con financiamiento Ryan White. Y eso lo podemos hacer con mucho gusto a través de el departamento legal que tiene Fundación BAI. Por favor, escríbanos a info@fundacionbai.mx, y si tienen algún caso de un migrante que quiera irse a Estados Unidos, podemos coordinar junto con sus clínicas de qué mejor forma podemos hacer la transición a esas clínicas sin que se queden sin medicamento antirretroviral. Va a ser muy importante que sus centros de atención, yo sé que muchos de ustedes lo hacen, les den al menos 3 meses, ¿no?, de tratamiento para que puedan establecerse en ese otro país y tengan suficiente tiempo para poder hacer las gestiones y continuar con su atención. Pero sí existen programas de Ryan White diferentes en cada estado. No todos los estados tienen, no todas las ciudades tienen. Por lo general son las grandes ciudades los que tienen más acceso a esos programas, pero sí es posible y podemos hacer la investigación y apoyarles con eso. ¿Alguna otra pregunta, alguna otra duda?
Doctor, en su teléfono están las preguntas. Sí.
¿Perdón?
En su celular le mandaron WhatsApp.
Perfecto. Me están mandando... perfecto. La doctora... tenemos preguntas de la audiencia. Perfecto. Oh, we have questions from the audience because, as I was saying, we're broadcasting to 10 countries in Latin America. I love this because it's not only in person, we can access more and more people in the world. La doctora Rosa Álvarez Torres pregunta, quisiera de manera muy especial felicitar al maestro Ben Young, no se diga por favor doctora, el doctor Carlos Cabrera, y quiero también agregar a la directiva del GEVIHS. Ella es del Capacis Ensenada, pues definitivamente son puntos más que importantes, no solo como médicos, hagamos un buen trabajo, involucrarnos de forma más activa en la atención integral y lograr, perfect. So, she's Dr. Alvarez from Ensenada, California, talking about burritos in the border with San Diego. She wants to congratulate you, acknowledge your leadership and this conversation, letting you know that she thinks you're very personable, accessible, and what you taught us today in this conversation inspire us to get more involved in the integrative care of our patients and achieve the fourth 90 in the UNAIDS goals. So thank you. Would you like to add anything about this topic, the UN
Well,
goals?
first, muchísimas gracias, doctora Alvarez, for your comments, por su comentario. Son palabras muy profundo. So fourth 90 is the idea that first off, that viral load is not the end of medical care. Success in medical care does not end at viral load. There are many other factors important, such as the fourth 90, which is often discussed as quality of life. There's a whole nother discussion, probably another Plática about quality of life, but we should be asking people, not just our patients, not just about their viral load. We should not be telling them what quality of life is, but asking them about how they define quality of life, and ask them how close are you to having quality of life, or what are the barriers to quality of life. So quality of life is now a major effort in UNAIDS policy. I will say it's also a major effort of at least one pharmaceutical company, GEVIHS, in that many of the medicines that we are trying to develop are aimed at trying to improve the aspects of quality of life that our community advisors have informed us of. So these are things like the fear of medicines revealing diagnosis, the fear of the stigma of taking medicines, and so on. So this is stigma, it's quality of life, and it's a policy agenda that should be translated to the clinic.
Muchas gracias, doctora Rosa Álvarez, por su comentario y por su pregunta. Definitivamente hemos hablado y seguimos hablando e involucrando más el tema de calidad de vida, ese cuarto 95 de los objetivos de ONU-SIDA para tener una mejor calidad de vida en nuestros pacientes y poblaciones clave que viven con VIH. Y definitivamente la calidad de vida tiene que ver con el estigma, con la discriminación, con factores sociales, psicosociales y también biomédicos que nuestros pacientes enfrentan día a día y que sin lugar a duda al sensibilizarnos nosotros como sus médicos tratantes, desde luego que contribuimos a alcanzar ese tan anhelado cuarto 95 ahora para mejorar la calidad de vida de nuestros pacientes. Y pues bien, tenemos una última pregunta de la audiencia. Si alguien tiene otra, por favor que levante la mano, con todo gusto traducimos. Y la doctora Laura Juárez Morales nos pregunta, en este momento en nuestro país nos enfrentamos con muchas dificultades para hacer investigación. Hay desabasto de medicamentos y falta de promoción de la salud. Hace falta concientizar a los gobiernos de la importancia de la detección y tratamiento temprano de las personas que viven con VIH e involucrar a la sociedad para disminuir los tabúes que aún persisten. So, at this moment in our country, we face many difficulties to do research or to conduct clinical research. There are medications who are out of stock, and there is a lack of health promotion. How would you recommend that we sensitize our governments about the importance of testing and treating, as fast as possible, the newly diagnosed people living with HIV, and involve the civil society and, in general, the society to abolish those taboos on stigma and discrimination?
Yeah, so I'm very sorry to hear about the stock out of medications. This is a challenge in many parts of the world and very critical in HIV. The issue of government engagement is really important. It was recognizing all of that environment that actually led me and my team at my previous job at EAPAC to initiate what we now call the Fast Track Cities Initiative, to bring policy making and decision making closer to the clinic and closer to the community, because mayors of cities tend to be more responsive to these questions than federal government. And regardless of whether it was city or state or federal, the collaboration between policymakers, medical doctors, or medical community and patient community, that collaboration and almost collaboration between these people, these groups, to make sure that we continue to move the agenda forward towards more testing, more access to care, more access to medicines, and quality of life. That requires a collaboration between these groups. For one doctor in one clinic to start, I think it's very important to first get the community engaged, to make sure that what we are thinking is necessary is what is necessary for the community. We successfully did this in Denver in 2016, where we got the mayor to endorse 90-90-90 in the city. And so now the mayor is responsible for making sure that this happens in collaboration with doctors and community. But I think the idea of community mobilization to improve policy, to improve delivery, will be something that will always be a challenge. And again, a place where doctors can be not just doctors wearing stethoscopes and writing prescriptions for diagnostics and medicines, but could be writing letters and meeting with government officials and policymakers to make sure, so that doctors can be activists once again, right? You can advocate for the things necessary for the patients that we look after. And so I would encourage all of us, each in our own way, to listen to our patients, for what is happening, to take that to our government officials on a regular basis, if possible. Even if it's not acted on, the government has to know, right? Because without that knowledge and with the authority granted us because of our education, we have the ability to influence policy and decision makers much more than community at times. But the words that we say can be much more powerful and much more effective with the involvement of community.
Muchas gracias por la pregunta, doctora. Sin lugar a duda, muy trascendente. Y lamentar escuchar, ¿no?, estos comentarios tan desafortunados de que todavía en algunas clínicas o en algunos institutos existe o puede existir este problema en el desabasto, que, como hemos escuchado también de diferentes tomadores de decisiones, a veces se debe a esa falta de comunicación entre los almacenes y quienes solicitan los medicamentos para que lleguen a tiempo. Esperemos que eso se pueda resolver. Y en definitiva, creemos que el doctor conmina a todos a que concatenado con esa primera conversación que tuvimos acerca de cómo los médicos, los científicos, los que atendemos a pacientes con VIH, también debemos volvernos activistas en beneficio de nuestros propios pacientes, con la sociedad civil organizada y la sociedad entera, podemos sensibilizar a nuestros gobiernos a traer mejores oportunidades para la atención médica. A veces es muy difícil, esa es una estrategia muy importante. Es más difícil tal vez sensibilizar o convencer a un gobierno federal en un país, porque numerosas estrategias de políticas públicas tienen que aplicar. Sin embargo, él nos comenta que a su paso por la Asociación Internacional de Médicos o Proveedores de Atención en VIH, conocida por YAPAC, por sus siglas, como YAPAC por sus siglas en inglés, él fue una de las personalidades más importantes y autoridades. Ellos en YAPAC crearon un modelo que se llama Fast Track Cities, o ciudades que logran hacer que el tratamiento llegue de manera rápida y expedita a las comunidades o a los nuevos diagnósticos de VIH. Y de esta forma, él comenta que es, no diría tal vez más fácil, pero quizá menos difícil, sensibilizar a ayuntamientos, a alcaldes en las ciudades, porque son las ciudades en donde habitan las personas que tienen con VIH y que pueden también proporcionar o sumarse a los servicios de vinculación a tratamiento, etc. Entonces, este programa de Fast Track Cities y se firman convenios de colaboración entre YAPAC y estos gobiernos locales para poder hacer que, como lo vimos en San Francisco, ¿no? Si te detectan hoy, puedas llegar a la atención en una semana, y eso se ha reducido en una cuestión de días, ¿no? Muchos de nosotros sabemos que tal vez en nuestros centros, si detectamos a alguien hoy, puede acceder a tratamiento mañana, si hay algún médico que lo puede atender. Eso lo podemos documentar, o está de hecho documentado en nuestras hojas diarias, etcétera, por los diferentes servicios. Pero si logramos involucrar a los alcaldes de nuestras ciudades a que se sumen a estas iniciativas, podremos tal vez lograr en conjunto una mejor calidad de la atención en los servicios y tener una mejor trazabilidad de estos 90s en la atención. Entonces, me parece una idea muy importante. Identifiquemos, yo les invito, y también el doctor Young les invita a identificar quiénes son los actores clave de sus comunidades, actores clave con trabajo y experiencia en VIH, que trabajen en la sociedad civil, que puedan volverse aliados suyos, ¿no? Cada vez vemos más y más médicos que están involucrados con sociedad civil para lograr esos objetivos. Que no exista esa desconexión entre el médico tratante y sociedad civil, que no pensemos que todo es una crítica a nuestro trabajo, sino que aprovechemos las herramientas que sociedad civil organizada tiene en beneficio de nuestro trabajo, que nos facilite nuestro trabajo y que también ayudemos al paciente a mejorar su calidad de vida. Entonces, desde ya yo creo que vamos a empezar a trabajar, por lo menos en la ciudad de Mérida, y yo les invito en sus ciudades también, a empezar a buscar esos canales de comunicación con nuestros alcaldes, con miras a que firmen un convenio de colaboración con IAPAC y podamos ser parte de esas Fast Track Cities. En México existe una ciudad, ¿no?, que es la Ciudad de México, que es parte de este consorcio global de ciudades que están en este programa, pero podemos, con líderes locales, hacer esto con nuestros alcaldes. ¿Alguna otra pregunta? ¿Comentario? Doctora, ninguna. Muy bien. We're on time. It was a delight, a true delight having this conversation with you, Dr. Ben. And thank you so much on behalf of the Board of Directors of GEVIHS for your participation, and we look forward to seeing you again soon.
Gracias, Dr. Carlos.
Le agradecemos al doctor Carrera y al doctor Benjamin por excelente charla. Gracias. Bueno, pues no por último es menos importante el siguiente tema y último de este magnífico congreso. El siguiente tema es Crónicas de 20 años, impacto de GEVIHS a lo largo de la historia de VIH en México. Y obviamente, la persona que lo presentará es la doctora Zoila Magdaleno Sandoval. Es maestra en Salud Pública en Servicio del Instituto Nacional de Salud Pública en Cuernavaca, Morelos. Cuenta con diplomado de urgencias médico-quirúrgicas. Pertenece a la Asociación Mexicana de Medicina de Urgencias AC, con educación en medicina continua y estudios de posgrado. Tiene diplomado en urgencias médico-quirúrgicas de la Benemérita Universidad Autónoma de Puebla, con mención honorífica en el Diplomado de los Derechos Humanos y Protección a la Salud, de la Universidad de Quintana Roo y de la Comisión de Derechos Humanos. Cuenta con el certificado de competencia clínica en medicina del VIH, con reconocimiento a la aprobación del examen GALEM desde septiembre del 14 por el IAPAC. Cuenta con